related to one's healthcare and end of life matters should the unfortunate arise. More specifically, we will be talking about medical aspects related to healthcare powers of attorney and living wills. Stay tuned to discover and understand how living wills are actually implemented in medical facilities. I'm Jeff Rehmeyer. I'm an attorney and president of the CJ Law Firm. Historically, my practice has involved estate planning and administration, business, and real estate. Now, I'm emphasizing estate planning to include planning for young adults. On today's show, we again have Dr. Michael Spangler. So welcome, Doctor.
Glad to be here. Thank you.
In our show last week, I spent some time on Dr. Spangler's impressive and extensive resume. Suffice it to say, he's experienced, he's educated, he's involved, and he currently serves at UPMC Memorial Hospital as the Vice President of Medical Affairs. So again, welcome, Doc.
Thank you.
So before we get into living wills, let's talk a little bit about medicine at large. And last week, you did talk some about telemedicine and a little bit about technology and how things have changed recently. And I thought that was very interesting. I didn't realize some of those advances were helping with healthcare. But if we look ahead, what do you think is going to happen with medicine in the coming 5 to 10 years? What changes do you envision developing further?
Yep, I think you hit it out of the park with the first comment you made with telemedicine. Like I said, COVID has changed the way we use telemedicine. We went from little usage to tremendous usage during COVID. Now that COVID is backing off, I think it's going to be very important that we maintain a razor sharp focus on what telemedicine looks like going forward. Reason being, I think there really is three aims for medicine going forward. I think the Institute of Medicine did it really nicely several years back, where they talked about the triple aim, where it's access, quality care, and decreased cost. And access is all about telemedicine. How are we able to provide medicine to people on their schedule rather than necessarily on our schedule? And I think telemedicine does that nicely. Somebody goes to work, they have to work and do things, you have kids, whatever. You want to be able to have your visit whenever you need it. And that could be off hours, that could be over a lunch hour, that could be whatever fits into somebody's schedule. Because let's be honest, the ultimate aim going forward is population health, is how do we make the population healthier so we don't have to worry about the chronic disease that end up people in the hospital and spending huge amounts of time in the hospital. And interfering kind of with some of the acute care that we're doing in the hospital as well. So like I said, I think telemedicine figures in that population health quite well. I think we as a healthcare entity really need to figure out how to decrease cost. That's the hardest thing. And at the same time as you decrease cost, we have to assure that quality is forever improving. All of these fancy toys that we have in the hospital right now, all the advances that we have, where is the return on that as far as we are having high quality medicine? I mean, you look across the world, you would think with all the healthcare expenditures that we have, that our quality of care in the United States would be high. In reality, when you look at it, we're not near as high as you want to be. I mean, we want to be top 1 or 2 in the world as far as healthcare is concerned. And looking at that data, we do poor at best with all the resources that we have available to us. So, like I said, I think over the next 10 years, I think those most successful will really figure out how to gain access or give access to everybody that you can at a highest quality that can be delivered at a cost that kind of revolutionizes what we're doing at this point in time. So,
as you talk there with the triple threat or whatever term you use for that, it made me think of the saying that in business, you can have it 2 out of 3, good, fast, or cheap. But it sounds like you're shooting for 3 of 3 here, which is encouraging.
Yep, absolutely. Absolutely. And like I said, I think telemedicine has caused that access part to be something that's within reach. So I think if we talk about 2 of 3, I think those other 2 really need to be focused on as much as we did with telemedicine here as of late.
So the trade-off with the physicians is telemedicine makes it easier for them to do it, and that potentially opens up different hours for them. Because It sounds like you promised a lunch hour appointment, which is an interesting option.
Yeah. And it's amazing. We actually had radiologists here interpreting our studies overnight that were actually out in the West Coast, because they're during the daytime at that point. but they can interpret the studies. And with telemedicine, they have the high resolution computers so they can see exactly what the image looks like and have real-time feedback. So that way, rather than having somebody here that's burning the midnight oil and tired and maybe not as acute, especially in the world of reading radiologic images, they can be out in California or Hawaii or wherever reading these studies of high quality. So like I said, I think it's amazing, and ways that we can not only assure that access point, but we can actually make life a little easier even for the docs in the backside, which that wouldn't hurt sometimes either. Prevent burnout and some of those other issues that we're dealing with in medicine. So
excellent. My optimism is raising by the minute here. All right. So in terms of the field of medicine right now, what would you say the biggest challenge is that medicine is facing?
Yeah, I think right now it's really the overall chronic disease states that we have. Like I said, we have so much diabetes, so much hypertension, so much obesity. I mean, the list goes on and on of chronic health conditions. And what happens is the earlier we enter healthcare with chronic disease states, the more dependent we are on the system. Hopefully that makes sense. Like, put into existence, somebody develops congestive heart failure at 30 years of age or 35 years of age. That person, I mean, congestive heart failure ebbs and flows the disease process throughout the course of life. And like I said, unfortunately, the use of the healthcare system is tremendous, where resources are sometimes scant. So like I said, I think a lot of our efforts need to be focused on what prevention looks like and what overall population, a healthier population looks like. Meaning, hey, you know what? Let's encourage people to be using their primary care physicians more often. Let's make sure that primary care options are out there for people. And I got to be honest, I think we as a healthcare entity need to push on insurance companies to say, hey, you know what? We need to be able to really kind of enforce that preventative care aspect more than the aftercare aspect. Mm-hmm. I mean, like I said, I think some of these insurance companies that do, I know my parents were in Medicare, where they were talking about the Silver Sneakers program, where you get access to a gym and they can work out, and you can have access to either nurses or physicians to talk about life counseling and those kind of things. Those are the things I think that are going to be most influential going forward. Like I said, our population is continuing to age, and as our baby boomer population really kind of gets into that chronic disease state, it puts a tremendous stress on hospitals, on healthcare networks, on the whole kaput. So everything is impacted by it.
So just to unpack some of that answer, I think I heard an ounce of prevention is worth a pound of cure. And Absolutely. One of the goals is to encourage insurance companies to recognize that preventative actions are a big part of our solution here. The other thing, and I promised you that I would ask questions to make sure I fully understood everything, but when you refer to a chronic condition, chronic disease, what specifically do you mean, doctor?
Okay, good question. Those are the things that basically cause the repeat visits to your doctor. Let me put in, for instance, so you end up with influenza. Okay, we try to do everything we can, but every year influenza is around. If you get an acute visit for influenza, you got to see your doctor, or you may need to see your doctor. Okay, so that's an acute visit. Let's compare it to a patient who has developed diabetes, that they have to have their routine eye screens done. They have to get their podiatric visit, or the look at their feet because of the sensation in their feet. They may end up with kidney issues, so they'll have to probably see a nephrologist at some point in time, the endocrinologist that they need to see because of watching and managing their blood sugars over time. And these are visits that people are going to have to see a doctor in the early stages, maybe every 6 months, but as things progress, it could be every 3 to 4 months that people have to re-enter into the system. And let's be honest, the complications involved with a type 2 diabetic over time, increased risk of heart disease, as I talked about, the increased risk of kidney disease. These things add up over time, and like I said, it's tough as a physician. You follow these people lifelong, and you see the recurrent visits to the hospital as people have more and more complications of that chronic disease state. Like I said, it's tough. The like you said before, if we could have healthier lifestyles with exercise, with diet, with all of that, with lack of a sedentary lifestyle as a whole, we may actually be able to maybe not fend off diabetes forever, right? There's a lot of genetic markers and things that make people diabetic, but if we can prevent chronic disease from occurring even a handful of years, even 5 years, think of the difference that it makes with utilization of healthcare resources at that point.
So a chronic would be a long-term illness that perhaps never gets better.
Correct.
Just gets worse and the complications get greater.
You got it. Yep.
Okay. Well, in the prior episodes, I talked about some of my work doing estate planning, and I talked about the 3 primary documents: the last will and testament, which we're not going to focus on today, what happens with your family, with your things after you die. We talked about a power of attorney, which allows somebody to make medical or financial decisions for you, pardon me. And then we talked about the advanced health care directive, which has 2 components. One is the medical power of attorney, who can make medical decisions if you're unable. And the second is the living will. And if I were to summarize, and you can chime in, but a living will comes into play if you are in an end stage medical condition that will result in your death, or you're permanently unconscious or vegetative.
Right.
And I would say, doctor, whenever I do estate planning for anybody from the age of 18 to over 100, I do that advanced care directive, and the living will is typically the most discussed document. And it's typically discussed because people struggle with how and when it's implemented. I have some clients that say, don't let me linger, pull the plug. And then I have other clients that say, don't let somebody pull the plug too soon. So what I'd like to talk to you about today is what sort of circumstances will cause the living will to become a document that's a factor. And can you help me and help others understand when it will influence a decision or when it will not? What sort of medical conditions are necessary to invoke it?
Absolutely. And I agree with you 100% that it's the most misunderstood part of this document. There is no doubt. I think what you said, just to kind of frame it up a little bit, is very powerful. That says, if you're in an end stage condition, okay, so let's give it for instance, and I'll start with COVID because it's on everybody's mind. And I think I talked last time, I can't do a talk without mentioning COVID at some point in time. So let's talk COVID. Let's talk a patient who is 45 years old, healthy otherwise, that ends up with COVID. And let's make it a male, because males typically enter the healthcare system a little later. So this person's been sitting on their illness for 6 days, 7 days at this point in time, and getting progressively sicker throughout. When they come into the hospital, let's say they are in real bad shape to the point where they would need to go on what we call mechanical ventilation, or put a tube in somebody's throat and have a machine breathe for them. That's not an end stage condition at that point in time. That's a potentially reversible condition that somebody got, whether you talk about a pneumonia, whether you talk about COVID, whether you talk about influenza, like we talked about earlier. These are reversible for a healthy person to get through for the most part. Okay. Now let's go the next step. Let's say that same person now is on a ventilator for, let's call it 14 days. So 2 weeks they're on a ventilator. And what we've found is that over time, this patient has gotten progressively worse. They're requiring more oxygen. They're requiring extra medicines to maintain their blood pressure because their body's kind of breaking down. They call that multi-system organ failure. In that situation, an acute patient can eventually go to the point where care starts to become futile. Now, the great question is, how do you know? How do you know when you get to that point? And I think one of the lost arts, especially with COVID, was all about communication. As a patient is in the hospital, we got to a point where people couldn't come into the hospital at all to see their loved ones. That talk was very difficult to say, hey, this healthy person before they came into the hospital is now to an end stage condition. That's rough. That's a tough one to have but one that we deal with on a regular basis. But in let's take COVID out of it. In that same situation, that patient has been on the ventilator for 2 weeks. Now, what we do every day when somebody's on a ventilator, we wake them up to where they respond, and when they can shake their head yes or no, little things, squeeze my hand, those kind of things. Let's say that patient not only is getting worse from a breathing standpoint, now is not responding or able to do those things because they're getting so sick. We do tests. We do tests on their brain. Their brain waves aren't doing well. They may have developed a stroke because they've been on the ventilator or been so sick during that process. Now you're getting to the point where the likelihood of meaningful recovery for that patient to get back to their previous state of health is not good. Now, let's go to your living will. In that living will document, it does talk about if I get to a point of end stage, end of life care, do I want to be kept alive with mechanical ventilation? Do I want to have blood products? Do I want to have antibiotics? All that kind of stuff. And that list can change over time. Like I said, a person originally can say, yes, I want to be on a ventilator, but they could have told their family, hey, you know what? I do not want to be kept alive by a machine for the rest of my life. And those are communications that and we talked about last week, if you pick a power of attorney that understands your wishes, can make that decision as that disease progresses further. Okay. So the physician starts coming up and saying, hey, you know what? The likelihood of this, of mom, dad, sister, brother, or whoever, of getting back to being able to function and walk around independently again is not going to happen. Their disease is to the point where they're going to need a ventilator and be on a ventilator for the rest of their life. They're probably not going to be able to talk again. We're concerned that even their brain isn't functioning the way it needs to. At that point in time, that power of attorney has that ability to say, okay, we've had enough. Now, like I said, one of the things I get a little bit concerned with is that term of pulling the plug. It's not pulling the plug. It's basically, I'm adhering to the wishes of that particular patient. And I think that's the important thing. And I told a story about my dad, I think last week, where I had to make this decision for him. But I knew he did not want to live with a machine doing the work for him. Quality of life, the death with dignity, all those things that we talked about last week come into play when it's time to say, okay, we trust in the medical system that these potentially reversible things, we get better. But unfortunately, people do die of a disease process at times. And we need to understand that process exists. And we need to trust our healthcare providers to be able to have those tough discussions with us and let us know. Now, like I said, if that same person would say, okay, we're 2 days into it, they're getting a little better on the ventilator, and the family's saying, or the power of attorney saying, hey, you know what, they wouldn't want this. That's the job of the physician then to say, hold on a second. We see things going the right direction. We really think that recovery is there. Give us a couple more days and we'll revisit this discussion a little further down the road. So hopefully you can see the parallel process, that one veers in a bad direction, the other veers in a positive direction. And that's where we as healthcare providers need to help you and be able to guide your power of attorney through that process. And when is the time to enact that living will? Does that make sense?
It does. Just to expand, and from my understanding, so you're in the facility, you can't make your medical decisions. Your agent under the healthcare power of attorney is making decisions for you, presumably among options that will help you recover meaningfully.
Right.
At some point, if that recovering doesn't look like it's going to be meaningful, then you're looking more towards the living will, which, absolutely, as I understand it, is the patient's declaration in advance that if they're in that end stage medical condition and there's not going to be a recovery, that they do not want to have their death prolonged.
Correct.
So maybe, and as a lawyer, maybe I'm looking for a point in time or a switch where that occurs, and perhaps it doesn't, but help me understand that transition from we can do one or two or three different things to help the patient to nothing's going to help the patient, and therefore we need to look at what the living will says.
Yeah, you bring up a great point, and I wish there was a black and white answer for you. Unfortunately, in this situation, there's more gray than there, and really the way we look at it from a physician side, from a healthcare side, is there is an entity called multi-system organ failure. And that really does kind of guide things. So let's say you have a person on a ventilator for a period of time, and it's just their lungs that are the problem. Well, they're on that machine for 5, 6, 7 days, and then all of a sudden their kidneys start to get worse. And now we're talking about, do they want to go on dialysis or not? So a second machine to keep them alive. And then a little while later, you start saying, okay, well, all the wheels are falling off. Now we've developed a pneumonia in addition to the original problem. And at that point in time is where we start saying, okay, here's the issue. Now, bear this in mind. This whole process changes based on the patient, because no two patients are the same. So you take that healthy person that we had in the original description, and now you change it to a person who has an end stage lung cancer. That decision happens a little different based upon what that looks like. We'll go back to see if I answered your question first, because I do want to address a little bit of that chronic disease state too. Did that answer your question? If it didn't, I can reword it, I promise.
Well, I think you did. To me, it sounds as if it's not a switch so much as a trend that becomes evident.
Yep.
And that trend can be evidenced by the type of problems and perhaps the multitude of problems. And you're saying that medically, if somebody's heading in the wrong direction, you will often see things pile up, problems pile up.
Yep.
And that's really what does it. I don't know if my question is best suited now or later, but I'll just put the question out and we can decide if you want to do it now or later. But
sure.
I'm curious how many physicians are involved in making these determinations.
That's a great question. Frequently, a person ends up with an attending physician, so one provider that actually is kind of in charge of their medical care at that point.
Mm-hmm.
Most of the time, that one physician with the power of attorney is probably adequate to make that decision. However, when there is conflict, which it can happen, between that power of attorney and that physician, let's say the power of attorney saying, okay, I'm hearing what you're saying, but I'm not sure I agree with that yet. That's when we bring another physician in to have that discussion. And there are times that we actually have to go another step. Each hospital, at least each of the hospitals that I've been in, has something called an ethics committee, which means that committee normally that's composed of physicians, nurses, social workers, clergy frequently is in it. A lot of times we have lay people in it as well that go in, review the facts of the case, and really kind of start thinking about what that ethical decision really should be. And they'll listen to the attending physician. But like I said, there's physicians on that ethics committee that says, yes, this is the time when we need to do that. Now, frequently we'll do that only when either one, conflict arises, or number two, in the setting where a decision can't be made. Now, like I said, in the situation where a patient or a person did not have that discussion, did not set up the living will, did not set up the power of attorney, now you have family that's kind of at each other. One person wants to look for that miracle situation. The other one says, hey, you know what? Dad wouldn't want to go through this. Now you have this dynamic that isn't healthy for anybody. That's a perfect time to have a third party come in, like an ethics committee, to have these decisions, to help start making the decision on behalf of the whole crew that's taking care of that patient.
So your answer is emphasizing the importance of a discussion in advance with the person or people that you name as your medical powers of attorney, so they can better understand what you want.
Absolutely. Absolutely.
Again, just to recap from my perspective, the triggers under the living will, end stage medical condition, which, as I'm understanding it from our discussion, really means you're likely unconscious or unresponsive because your body's shutting down.
Yeah, right.
Or permanently unconscious or permanently vegetative. It's
Correct.
an or, correct?
Correct. Correct.
Okay.
Yeah. A permanent vegetation state is a tricky one. That means that you can keep a person alive with a machine for an undisclosed period of time. And that's a tricky situation. That's where some of these miracle questions come in. Everybody's seen something on a movie or television or something that somebody's been in a vegetative state for 5 months and now they're walking and talking and doing everything else. I have to be honest. I've been doing this for a while. The bald head will prove that I've been doing it for a while. But that miracle state I haven't seen, and I'm going to be very, very honest with you. Like I said, when we had our discussion last time of a person, like I said, my dad's situation, I consider it one of those medical miracles, but his was immediate, right? He had a cardiac arrest that happened in the field that if it happened anywhere else, he probably would have died. But for some reason, he survived and was able to walk, talk, and be normal completely thereafter. That's a miracle to me. That's a great thing. I mean, we wouldn't stand in the way of that. We as medical professionals, we say, hey, you know what? This is the person that we have to do with. Let's go. Let's fix it. Let's see what we can do. So that, in my mind, is that medical miracle that we look for. The medical miracle of the person who had, I'll put this into perspective for you. Let's say I've had patients like this in the past, that a young person that has a freak accident to where they start bleeding into their brain. There are conditions that is non-reversible. Now, bear this in mind. The rest of the body from here down in that 30 whatever year old was healthy, completely healthy, doing great, running, doing whatever they do. It's just here on up that's the problem. So you can keep the rest of the body going, just the brain will never recover from that initial event. The way we know that is there's testing we can do on the brain, even in somebody who's in that state. EEGs, they're electrical waves. We can see, is there activity higher in the brain? Is there activity in the midbrain, which is innate, like can they breathe? Does their heart beat? Those kind of things that the real deep part of the brain does. So it basically says that only the functions to preserve life exist, but nothing above that level actually is functioning. That's a tough decision. Now, if somebody had that discussion, like I said, if something like that would happen to me tomorrow, I have a living will that says I do not want to be kept alive in that circumstance. My wife knows that. My kids know that. Even at 14 and 16, they know that. So in my family, that would be an easy discussion, but it's a very, very difficult discussion for people who've never had that discussion before. So that's where getting these documents done earlier helps. Now, trust me, there may be people that say, absolutely not. I disagree with that. I'm looking for a miracle. Just because I personally don't think that would occur does not necessarily mean that everybody has to adapt to what I am. But I do think that's a patient to patient kind of difference. Okay. Like I said, that healthy person with no medical problems, okay, maybe. But that patient that has end stage lung cancer, that we can't do chemotherapy anymore, that eventually that cancer was going to be the cause of their demise, ends up with that same bleed into the brain. That one's not the one that continuing medical care forever is going to be even an option in that patient. So like I said, I think there is a continuum or a place where you can kind of say likelihood of meaningful recovery. And like I said, to me, that's more important than necessarily looking for that miracle. Because let's say you have a miracle, whatever that means, in a end stage lung cancer patient, and they survive a bleed like that. Well, that's true, but their cancer within the year would lead to their demise anyway. So like I said, it's a difficult balance in that conversation. And I probably confused you more, but
no, you didn't. But some takeaways that I'm getting again are: one, have the discussion with your agent.
Yes.
Two, it sounds to me like the medical professionals involved are undertaking an ongoing analysis that creates a perception of the likelihood of a meaningful recovery. And a lot of times it sounds like that is trend based, if you will, meaning where do all the signs point?
Yep.
And if nothing's pointing in a positive direction, then you're looking at more of a living will circumstance. But if there is some positivity, then there's a chance, and then you're having a different discussion.
Absolutely. And I think we need to make sure when we pick that power of attorney person, we pick somebody who's going to be actively involved. It is so important for the power of attorney to understand that trend as well. That communication, they should be able to know exactly how to get a hold of that attending physician. They should be having daily discussions, maybe even twice a day, depending on what the situation is, with that attending physician, understanding what the goals of care are, understanding where they're at now versus where they're at tomorrow versus where they're at 3 days from now. A great attending physician or a very good attending physician should set those parameters out there. Hey, you know what? We'll be doing good if the amount of oxygen that this patient is requiring goes from 100% down to 80% within the next 24 hours. These are goals that make sense. So that way the power of attorney, when they walk in the next day, okay, so did we get down to 80%? No, sorry, they actually went the opposite direction, and now we're adding more medications on. If we're able to get those medications off in the next 24 hours, we're going really well. Come in the next day, we weren't able to do that. Now we're having an additional problem. That sets the stage for communication, that the doctor knows that the power of attorney knows what's going on, and the power of attorney is constantly informed of where those small wins come and where the losses are coming from. And I think that's where that gray zone ends up starting to become clarity, when we all start talking the same language. Now, don't get me wrong. Your power of attorney doesn't have to be somebody that has a medical background. You don't have to have one of your kids go to medical school just to become your power of attorney when things come to it. But like I said, through regular communication, the doctor should be able to convey all of that to your power of attorney. And with the idea that the most beautiful part of this is the power of attorney knows that patient before all of this happened. We as physicians have no idea, right? Unless your primary care provider is actually coming in to care for you in the hospital, chances are we don't know that patient before they come into the hospital to take care of them. That power of attorney comes in and says, you know what, even though mom is 85 years old, last week she took a bus trip to Atlantic City and was walking around and having a great time with her friends. That's different than, you know what, mom's 85 years old, has told me multiple times that she wants to be with dad because dad died a while ago. And she's kind of given up, and she hasn't been watching her diabetes, and she's been missing a bunch of her medical visits. That's a totally different discussion. And that line to where we start entering fetal care can be very different for those two types of patients. Does that make sense?
It does make sense. Interestingly, doctor, I do seminars where I talk to employees at places of work and do webinars. And part of what I've started doing is to talk about attributes you may want to see in somebody you select. And as you were talking, I wrote myself a note here that says communicator,
Yep.
because I really got that as a strong takeaway in your agent.
Absolutely. Absolutely.
In terms of timing and consideration of the advanced care directive and living will, I'd always understood that if you're in an ambulance with paramedics, that document's not out. You're just being kept alive. You're being taken to a facility.
Yep.
I've been told if you're in an emergency room, the same thing is probably true as well.
Correct.
Is it beyond that point when this document starts to matter, when there's a chance to get beyond the initial event that caused you to need the care, to look at your current condition and the trend?
Absolutely. Absolutely. We go into that acute versus chronic again. I tell people, you know how when you're getting ready to have a baby and you start putting a bag together that says, hey, when that water breaks, my husband's supposed to go pick up that bag, throw me in the car, and let's go, right? I think that's where this living will is supposed to live. Okay. Put that in that container of, hey, if I get real sick, I have a binder that actually has that document in it, the original document in it, that I can grab, take with me, and go to the hospital. Okay. So I think that's an important piece. I know a lot of people who say, hey, you know what, I brought it in last time, it should be on your file. Don't rely on that. I mean,
Mhm.
as much as I love computers, I'm not sure I trust that everybody uses a computer the way it always is meant to work. So always bring that original with you, because that's the most powerful document that you have in your possession. So that's number one to help answer your question. Number two is, it's very difficult in an ambulance environment or sometimes in the emergency environment to identify what is potentially reversible and what is not, right? You don't have all the facts at that point in time. Okay. Mom ended up with a pneumonia and got real sick. Well, I've seen people with walking pneumonia that do
Mhm.
really, really well. I've seen other people with really, really bad pneumonia and can walk around and do really fine. I see people with mild pneumonia that don't do well. So, like I said, we don't know, just because somebody's having difficulty breathing, and even just because somebody's having an acute heart attack, doesn't mean that the outcome is going to is non-reversible. Okay, so in those first couple minutes of taking care of the patient, the idea is to level set what is potentially reversible, what is not potentially reversible. Okay, at that point in time, it could still be in the emergency department that things start to kind of show itself. Now, let me change that dynamic a little bit, because you take a patient in that end stage cancer setting, okay, that already they know that they're in a terminal medical state. If they say, and they have their living will there with them, I come into the hospital, I do not want to be intubated, because if I get intubated, I'm going to die on that machine and I know it, or the outcome's going to be bad. And trust me, life has been bad up until now. That document can be very valuable in those situations. And I do know that my providers here in the emergency department will acknowledge that in that patient population. Now, you bring in the patient that is having an acute heart attack, that can't breathe, that never had any medical problems. Waving that form, a lot of us would say, whoa, hold on a second, what's going on here? Some people say, well, his mother died on a ventilator, and they just don't want to die on a ventilator, and we don't want to see that happen. I get that, but this is a separate situation probably than his mom was in at whatever point in time that they went through this situation. So, like I said, there can be a myriad of times when that comes out. Now, in I'm an internal medicine physician, so I get the patient after the emergency department has identified that the patient needs to stay in the hospital. That document is worth its weight in gold for me to know, for me to read, for me to have in my hands, for me to make sure that we have a copy of it. Because once you bring in the original, I want the original to stay with somebody. But as long as I see that original, I throw it in a copier. Okay, we have it for that patient's stay. We communicate throughout that patient's hospital stay. That's
Mhm.
hugely important to me. Does that make sense?
It
So,
does make
so
sense.
it's normally after that. I'm going to call it a preliminary workup. Let's be honest. In the emergency department, by the time we get an X-ray, by the time we do an EKG, by the time we draw some blood work, within that first 30 minutes to an hour, we really have a good idea of what's going on with the patient. You might be in the emergency department for a couple hours. That's not saying that that's out of the realm of possibility, but we know so much about that patient during that first hour after all that preliminary stuff is done. That's when that document becomes handy, especially if somebody's doing poorly.
So if somebody watching this video is in an accident tonight,
Yep.
bad car accident,
Yep.
and their head gets smashed in the accident and they get taken to the ER,
Yep.
how quickly would a living will be utilized?
We would stabilize that person first.
Mhm.
With a mangled situation, we would establish an airway. We would do all the X-rays and CAT scans and everything else that happens. Once that patient has gotten into either a medically stable state, which means their blood pressure is good and everything is kind of going on autopilot at that point in time, or the wheels are falling off. in spite of all this medical care, we're doing thing upon thing upon thing, and we just cannot get that patient back. That document comes out. Does that make sense? Now the tricky part in that situation, so you're in that car accident, chances are you don't have your go to the hospital duffel bag with you. So you're going to be relying on your power of attorney in the optimum situation to bring that document along in with them. So like I said, they should have it in there ready too, or at least know where in your house where to get that go bag and then bring it in. Now, the cool thing there is by the time probably that process happens in the hospital, we'll already get through that first half hour, 45 minutes, whatever, to really kind of give a good idea to the power of attorney on which direction things are going to go.
So it sounds to me like this is, of course, very fact specific when it occurs.
Yep.
But it sounds like the medical care is advanced to the point that with some time, and it doesn't sound like it needs to be a lot of time, there can be a well-determined diagnosis of somebody's condition in which way they're headed.
Absolutely.
And if it's headed in a positive direction, there are markers that can be understood to evidence that occurring. And if not, then usually they will degrade in a negative sort of direction, and you start to see that happening.
Yep, absolutely.
So It's not a rushed nor a decision. It's not deliberate. Rather, it's very specific and deliberate.
Absolutely. Now, like we said, there's multiple ways to get into that bad situation. But like I said, that's when we need to, there's a level of trust here, but we do need to trust those medical professionals to do what they're trained to do and to do it well.
So just to follow up on that, when you said there's multiple ways to get in that situation, can you give me a few examples of when the living will comes into play? And you did one about the young person in the accident and the brain bleed.
Yep. Let me give you two others. I'm going to give you the easier one first, and then the harder one. The easier one is that setting of you have that that mother with lung cancer that's getting worse by the time. Okay. There comes a time sometimes in medical management of a cancer patient that difficult conversation is had with the oncologist or with whoever's caring for the patient that says, at this point in time, we have done everything that we can do. And eventually, unfortunately, cancer is going to win in this situation and your loved one's going to pass. Okay. At that point in time, a lot of things change. Okay. We say, hey, you know what? Some people, this goes back to your other little check marks on your living will that says, hey, you know what? If I end up with a little infection on my skin, I can take antibiotics and that'll go away. That's not going to prolong my life, but that's going to make my life easier to live. Right.
Mm-hmm.
So in that particular case, that living will is very, very important. And it can be literally any time that we can give that document because we have identified that patient is terminal at that point. Okay. So that one's an easier situation. And like I said, just like that brain bleed in the young person, it's easier, but hard at the same time because they were healthy beforehand. Now let's change the dynamic a little bit. Let's say a person was just diagnosed with lung cancer a month ago, has only gotten their first treatment so far, and has and is on chemotherapy and radiation and all that kind of stuff. So they started treatment in hopes of improving. Okay. That the goal at this point in time, because they're only a month into it, because a lot of that stuff, you're not going to notice a huge recovery that quickly. The goal is, I'm going to get better from this. I'm going to beat cancer. I'm going to be back where I was before, or at least some reasonable facsimile thereof. In that patient, when they come in with a potentially bad thing, COVID, okay, living will, we're not going to jump right to the living will right away. Because like I said, that person is living life and receiving treatment to a degree that they're just like, hopefully, you and I walking around on the street right now. As things progress, Okay, COVID's getting worse. They're now going to need to go on a ventilator. That's a tough one. Okay, and that's one of those where that really good, strong power of attorney that knows your wishes knows what's going on. In my situation, when I normally handle these situations as a physician, I normally say, hey, this person expressed a will to continue to live. I would probably opt to intubate that particular person or have them on a ventilator, at least for a period of time, to see if we can get this going in the right direction, get them off the ventilator, and go from there. So, like I said, that's a really, really sticky wicket, if you would, as far as which direction we go with this. This is the most medically complex. This is the one where physicians sometimes end up having their own ethical deliberation on what to do. This is when frequently you'll have multiple different subspecialists that are on the case, or they ask one of their partners to come in and see a patient to give another perspective, because like I said, determining that ends up being tough. Like I said, that's why we go to school. That's why we do what we do, to make those tough decisions. And that's where that communication with your power of attorney is worth its weight in gold. So like I said, you can see those three different scenarios can play out three very, very different ways. But the commonality to all of them is, while the patient is healthy, they need to have these discussions. You need to have the discussion with the power of attorney. You need to have the discussion about what exactly is written on that living will, so it's crystal clear what the wishes are if and when this situation arises.
I was going to ask you for a final piece of practical advice, but I feel like you just preempted my question and gave it to me.
Sorry about that. Yep.
No, okay. So I appreciate what you said, and the information medically was fantastic and enlightening for me. And my takeaway, doctor, is A, you do need to have that discussion, and B, if you encounter medical challenges, the discussion needs to develop with your physician or physicians, and that's going to start to set the path that you may be on, and then the document can come into play.
Absolutely. And if somebody ends up with a devastating diagnosis while they're in the hospital, let's say you come in and you're having just a little bit of belly pain, and unfortunately with some scans they find out that you have cancer all over the place. Again, nobody likes to have that discussion, but let's say that scenario exists. Being an advocate for yourself is important, to say, hey, do you have anybody in the hospital that can address a living will with me? Let's say you've never done that before. Hey, can we have that discussion? Especially while physicians are throwing a whole bunch of treatment options and all kinds of crazy nonsense that sounds like some kind of different language at that point in time. Getting somebody to come in to actually get that document done, get that power of attorney assigned as things are enveloping and going a million mile an hour, while that person is of sound mind to make those decisions, is also a time that's very, very important. So being an advocate for yourself, I mean, obviously I personally prefer you do it ahead of that. But if you are stuck in that unfortunate situation, that's one of the first questions that I would press people to have. And like I said, a real good inpatient physician would have that discussion as well. Do you have a power of attorney? Do you have a living will? If you don't, can I get somebody to help you with those documents? I think that's what we try to get our doctors to say. Do they do it 100% of the time? Probably not. But who does 100% of anything at this point? But I think that's another point just to remember. That's my second take home. Put it that way.
Okay. But I know you've advocated for doing documents in advance, and I do too.
Yep.
And the Advanced Care Directive, while it has a lot of implications, is not a terribly lengthy document. Yep. I do them routinely in my office. I'm going to do a few sets today. I'm going to do one in about 15 minutes. But I have gone to the hospital to do them. So if you're stuck in that situation, it's not too late to get it. Although the better course is to do it in advance, because it's usually a much easier analysis and discussion than when you're in a hospital.
100%. I agree with you.
Okay. Well, thank you so much, Dr. Spangler. You already know, but just to preview for those watching this, I'm going to have you back on in a few shows. We're going to talk about organ donation. We're going to talk more specifically about the check boxes to which you referred on the power of attorney, and the specific treatment options that can be withheld or not be withheld under certain circumstances. So we're going to take an even deeper dive on a few of these topics. But I would thank you again for meeting with me today, for talking. It's obvious that you're compassionate. It's obvious that you're skilled, and you're a good communicator as well. So I see a triple play in you that's fantastic for a physician. So you're a credit to UPMC in our community. And thank you, Doc.
Thank you very much.
All right.